Thank you for the invitation. Happy to discuss with you why we are interested in measuring esophageal and transpulmonary pressure and what are we really measuring with this technique. My disclosure. So if we go back to the general principle of using esophageal pressure in ICU patients, we reported this in this paper. What are the really the principle and the potential application of having esophageal pressure in patients with respiratory failure? This is a paper from the working group of the acute respiratory failure section called the PLUG group, the Plural Pressure Working Group, which is an open group and everybody's interested can join. And we had this figure, which really is a schema of why we are interested by pleural pressure, and we'll see that we can replace pleural pressure by esophageal pressure. But the principle is that because the lung is in the chest, what pressure can be measured? Well, usually we measure the pressure at the entry, at the opening of the airway, which is displayed on the ventilator. It's a total pressure moving both the lung, and you have an illustration of the lung and the alveoli, and moving also the chest wall, because this is the total pressure. So if we want to know what's really distending the lung, because we think this is what's potentially harmful for the lung, what's also causing hemodynamic compromise, we need to know little, to be a bit more precise about the distending pressure of the lung, which is not exactly airway pressure minus body surface pressure, if you wish, but it's airway pressure minus what's around the alveoli, which is pleural pressure. And this is why we call this pressure the lung pressure, PL, which is simply the difference between airway and pleural pressure. The second interesting use of esophageal pressure or pleural pressure is to know what the respiratory muscles are doing. You see on this illustration, the red part is the diaphragm. And the only way to really quantify what the respiratory muscles are doing is to measure directly the pleural or the esophageal pressure. So we'll separate the two, controlled mechanical ventilation and active spontaneous breathing of the patient. So as I said, since the 50s, we know that the pressure measured in the esophagus show very similar very similar changes in terms of amplitude compared to the pressure in the pleural space. So people say instead of trying to measure the pleural pressure, which is really complicated, let's just put a catheter in the esophagus, like we put a feeding tube by the nose or orally, and just insert a balloon at the tip of the catheter so we can measure the pressure relatively easily. So when you do that, and really nothing very complicated, this is the kind of measurements you've got. So you have on the upper part of the curve the esophageal pressure, which, as you see, indicates positive pressure swings at each insufflation. And of course, these swings in pressure are similar to the swings in the pressure in the airway on the ventilator. Just to put the two together, you have here tracing during controlled mechanical ventilation. So this is the flow, this is the airway pressure, this is volume controlled ventilation, and this is esophageal pressure. Please note that the scale is the same for airway and esophagus. So because the scale is the same, we can compare the amplitude of the change in pressure. And you see with airway pressure, we see the pressure goes up to almost 40 centimeters of water. But the change in pressure on esophageal pressure is much smaller, maybe 10 centimeters of water. And this is a very interesting information because it tells you of the 40 centimeters of water we see on the ventilator, well, 10, like 25%, are simply used to move the chest wall. It's not distending the lung. What's distending the lung is the difference between airway and esophageal, which is here illustrated by the lung pressure, which we call the transpiratory pressure. And you see the part of the total pressure, which is distending the lung. And we will see this is one of the potential indication of this technique. Try to understand how much of the total pressure is distending the lung. This is a second very interesting paper you could look at. There is a video which is in the supplement of this manuscript in intensive care, where you can see how to put an esophageal pressure. And I also selected this figure because this is another patient where this patient you see is in pressure control, and you see this very small swings in esophageal pressure during insufflation. So compared to the preceding patient, this patient have a very small contribution of the chest wall. The other one has a relatively important contribution. This is interesting because if we see this patient, and you see the pressure goes close to 35 probably, we could worry a lot because we could say, well, most of this pressure is distending the lung. There is a very small contribution of the chest wall. So to try to understand what we measure, let's look at 3 different possible indications. The first one is use of the absolute value to measure the end expiratory pressure and to titrate PEEP. The second indication is to look at, we will see a calculated value, to look at the end inspiratory safe pressure. And the third one is to look at spontaneous ventilation. So this is a CT scan, and you recognize the mediastinum, the lungs, the vertebrae, and this is the esophagus, right? What's very important to take into consideration is that there is not one single pleural pressure, but in reality there is a gradient from, let's say, top to bottom because the patient is supine, and the real pleural pressure is much higher in the dependent region here than in the non-dependent. Okay, so if we measure the pressure here in the esophagus, are we measuring this pressure, or something in between? In addition, there has been a lot of debate about the validity of the esophageal pressure, mostly because clinicians were surprised to see such high pressure. We think of the normal subject in the pulmonary function test lab where we are used to see maybe negative values, and in an ARDS patient we see values of 15, 20 centimeters of water. So people tend to think this is an artifact. So we did a series of experiments. I'm not going to go into details, both in pigs, in human cadavers, to be sure that we are as close as possible to the reality of our patients. And first, of course, we check that there is a pleural pressure gradient. So this indicates the gradient in injured lung, normal lung. And this is compared to what you can compute with the CT scan. And in human cadavers, well, we know the gradient is maybe 10, 12, sometimes 15 centimeters of water. And regarding the question of what do we measure, we put a sensor in the non-dependent part, a sensor in the dependent part of the pleural space, and compared to the esophageal pressure. In pigs, you can see that the esophagus is very posterior, very close to the dependent part. And it's not surprising that the esophageal pressure is very close to the dependent value. So the esophageal pressure reflects very much what is the dependent pleural pressure. In humans, the esophagus is situated maybe more at mid-chest, let's say. And again, not surprisingly, the pressure we measure is in between the dependent and the non-dependent, maybe a bit closer to the dependent one. So we are measuring the pressure at mid-chest. So what can we conclude from that? First, that what we measure is very reliable and accurate. It's not an artifact, and I think we should stop talking about artifact of the mediastinum. It's a real pressure. But second, we should know that this is a pressure approximately at mid-chest. So one application of this technique has been proposed by our colleague and chairman today, Untitled Chapter and Steve Loring in Boston, is to say maybe we should try to keep the lung open at any expiration by making the difference between airway and esophageal pressure positive. This is a very nice example. You see the esophageal pressure tracing, and you see the end expiry value is maybe around 14 centimeters of water. So they say there is 14 centimeters of water. Let's try to keep the PEEP level a little bit higher. Here it's 16 to make the difference slightly positive of plus 2 centimeters of water. And I think this makes a lot of sense. And again, because I've showed you that we have validated the reliability of these measurements. However, it's only pressure at mid-chest, which makes sense also because this is probably where you have the higher risk of opening and closing of the lung. So the rationale of this approach, I think, makes sense, but we certainly need more clinical validation to be sure this should be or might be applied in every patient. The second application comes from a different reasoning. And this reasoning, is mostly based on the elastance. And it's based on what I've shown to you when looking at the relative amplitude of the two different traces on airway and esophageal pressure. So remember, elastance is pressure divided by volume. So when you think about elastance, you think about pressure. And this is a group of patients with high elastance ARDS, and you see the relative distribution of the pressure between the lung and the chest wall. These are patients where the chest wall has a very small contribution. So most of the airway pressure represents the lung distending pressure. This is another group of patients, same lung elastance approximately, but the proportion of the pressure dissipated against the chest wall is much higher, close to 50%. So some people have said maybe we should use a ratio of the elastance of the lung to the respiratory system to try to see what is the plateau pressure of the lung as a safe limit. This has been criticized because it makes some assumption, and especially that the end expiratory value is close to 0. However, when we look at the data from pigs, or I will show you human cadavers, well, we found this assumption to be probably not too, well, probably correct or close to being correct at the non-dependent part of the lung. Remember, the non-dependent part of the lung is the part which is probably at the higher risk of distension. And so interestingly, this calculation, so you take the plateau pressure, you multiply by the ratio of lung to respiratory system elastance. Let's say you have a plateau of 30, you have 80% of ratio, it means your lung elastance is at end inspiration is 24. And we know we don't want to go above 24, 25. So this seems to be a valid calculation in pigs and also in humans. So not saying it's perfect, but I think it's probably a very reasonable approach to limit the end expiratory pressure and inspiratory pressure, during mechanical ventilation. And there are interesting data suggesting it could make sense again. This is a study by Salvatore Grasso, where you see this is the plateau pressure, airway plateau pressure. So they calculated here the lung plateau pressure by this method of the ratio, and they had a group of patients where the lung plateau pressure was clearly very high. They say we cannot continue to increase PEEP or tidal volume. This patient should go on ECMO. And there's another group of patients, same plateau pressure, but much lower lung plateau pressure. They say for these patients, the distending pressure of the lung is not so high. We can increase PEEP even if plateau pressure goes up above 30. And they report that they did not submit this patient to ECMO. No outcome data really, but again, a physiological reasoning which makes sense. Third indication, very briefly, which I think is very important, but a little bit more complicated to put in place, is to monitor a patient during spontaneous breathing. And when I say spontaneous breathing, it's any form of assisted ventilation. Could be assist control, assist pressure control, pressure support, anything. So what you will see is this kind of tracing, right, with negative swings, because it mostly reflects the negative pressure generated by the respiratory muscles. And let me give you just one example. This is a patient who is recovering from severe ARDS, is doing better, is switched to pressure support ventilation. The pressure support is 15. So everybody could say, well, 15 of pressure, the lung of my patient is not at risk. But the total distending pressure of the lung is the sum of the positive pressure delivered by the ventilator plus the negative swings generated by patient's respiratory muscle. So if we were plotting the transpiratory pressure here, we would see changes of 15 minus 15, which means 15 plus 15, so a total of 30 centimeters of water. This is huge. This is a big risk for the patient. This is a big risk of what we call now patient self-inflicted lung injury. And if we don't do the monitoring, we may miss that. And I think, but we don't have enough evidence yet, I think this is a reason why we regularly see patients who worsen after being switched to pressure support. So I think this is a very important monitoring, but not yet ready for clinical use yet. Thank you very much.